So I think when you think about where is our field going and how could the research that we know is happening over the next 5 years, what are the unmet needs that we need to kind of merge them together so that we're ready for when new treatments come out, for example. So I think we only had a few classes of therapies since 1998. Between 1998 and 2014, we just had the anti-TNF class of therapy, really. And all that happened is we went from an IV formulation to a self-injectable formulation that's every month as opposed to every 2 weeks. So we weren't kind of changing paradigms of the immune system for a long time. And then we had a new class of therapy called the integrins, which vedolizumab is a member of that. And then last year we had ustekinumab, which is the IL-12/23. So we now have 3 classes. I have a patient sitting in front of me. I have no way of knowing right now with the kind of development or news we have to say, you should get an anti-TNF, you should get an IL-23 or IL-12/23, or you should get an integrin-based therapy. I'm not very good at telling a patient which one. All I can talk about is how long on market, what the 1-year clinical trial data looks like, what our off-label experience is. So imagine how complicated it's going to get with over the next few years, we're actually going to have even more targets. So imagine the idea that we need to be ready, let's say in 2022, in 5 years from now, we need to be ready to be able to say, you should get a TNF, you should get an IL-12/23, you should get an IL-23, you should get a JAK kinase inhibitor, you should get a JAK1/3 inhibitor, a JAK1 inhibitor, JAK2. I mean, you could see the confusion that will ensue both on the patient side and on the physician side. So our responsibility on the research side is to try and develop tools that will help the physician dictate what therapy would best work for that patient. Because one thing we know, the first therapy is the most important. Because what we've learned so far is the sequence of therapies is also going to be important, but our second drug doesn't work as well as the first, and the third, and it will be 5 by the time we're saying, sorry, you need surgery. So this also brings in the idea that we need to figure out who should go to surgery first and then what the post-op maintenance strategy would be, because you don't want to wait 5 years later and maybe ruin a chance of using that drug again in the future when the patient needed surgery. So a real unmet need will be to look at the tissue itself, meaning going to the colon or ileal biopsy and saying, wow, you are a predominant IL-23 maker and I'm going to use this drug. So personalized or precision medicine, taking a page out of the oncology space, using the platforms that they've used to figure out that who knew there, for example, are 5 kinds of lymphoma. You knew that by going to the tissue and genetically understanding, the treatment strategies. So that is happening in the background right now, because we know that by 2022 we have to be ready, or else it's going to be mass chaos in terms of, you have all these targets and patients aren't going to know what to do, and physicians are going to be either resorting back to their original TNF, and then if that doesn't work, go to an innovative therapy. There's also biosimilars that is going to complicate the space because the cost of those may, I hope not, mandate that we need to go down the TNF route first. So we'll be, of course, tracking that closely.
A really critical issue is what are the unmet needs in Crohn's disease? And I would say there are several. We need some additional first-line therapies that are quite safe in patients with mild to moderate Crohn's disease. And then in the moderate to severe patients, our best outcomes right now come with the early introduction of an anti-TNF agent plus an immune suppressive. But the problem is, from a toxicity standpoint, because of the immune suppressive part of that, you end up with an increased risk of non-Hodgkin's lymphoma, skin cancer, and serious and opportunistic infections. And all of those are undesirable. And if you don't give the combination therapy, the remission rates are lower, the endoscopic healing rates are lower, and the ability to stay off steroids and prevent disease progression is lower. So what I think we need more of in the years to come is additional fairly precision drugs that are not heavily immune suppressive, and ideally that could be co-administered, so you'd have 2 or 3 highly effective drugs that from a safety profile it would be acceptable to give as double or triple combination therapy. We're not yet at that utopia, so we're sort of looking to see 50 or 60% or more of patients have complete remission and healing with a favorable side effect profile.
There are multiple unmet needs regarding Crohn's disease treatment. We need to be able to treat the disease early in the high-risk patients with effective therapies. At the present time, because of third-party payer and insurance concerns, we often need to go through corticosteroids or immunosuppressives to move on to more effective therapies. A second important need is to replace corticosteroids. Steroids are cheap, they're effective at controlling symptoms, but they really do not impact on the long-term course of the disease, and steroids are associated with the largest number of side effects, both systemic side effects as well as risks of infection and even risk of death.
As agents with newer mechanisms become available, I think we're going to see a shift in the role of TNF blockers. TNF blockers are around now for nearly 20 years. We have a wealth of experience with them. They still are viewed as our most effective agent. We know a whole lot about how to tune their utilization to improve their efficacy. We know how to bring patients back from loss of response. So there's a lot that we need to learn about those same points with the newer agents. But increasingly, concerns about the safety issues of TNF blockers will lead us to use more novel agents.